make, or rather we have a point to make for this, so which is why they're included. So I've got candidates 3 and 4. It doesn't matter. I think let's stick with the 3 first for the first 7 cases, and then candidate 4 for the next 8 cases. Okay, so we have candidate 3. You've got a few MR sequences in front of you. Do you want to talk through this case?
Hello, I'm candidate 3.
Lovely.
This is an MRI images showing soft tissue edema at the right femur and greater trochanteric with muscle edema, soft tissue edema, and involvement of the cortex, which appear iso on T1 and hyper on T2. And on post-contrast, there is like enhancing well-defined collection seen, 2 collections. And can I have a clinical history of the patient, please?
Right leg pain. Right leg pain.
Does he have fever or anything?
Yeah, he's got a fever.
PSR elevated.
CRPs 70, white cell counts 25.
Yeah, findings are suggestive of infectious process like osteomyelitis, and this is most likely an aggressive appearance as infectious like osteomyelitis and abscess.
Okay, so quick question. If I didn't tell you the inflammatory markers, without the inflammatory markers, what would you have thought it was?
Of aggressive lesion, since there is an edema and the cortex be breached, and there is like enhancing collection. So I'll go with osteomyelitis or ewing sarcoma, aggressive lesion rather than just simple benign lesion.
Okay, thank you. So, well, and this is osteomyelitis. So you've got soft tissue edema. You've got this periosteo elevation. And yes, so this is a T2 fat suppressed, and you can see marrow edema as well here between the greater trochanter and the epiphysis, the metaphysis. And this is apophysis, which is similar to epiphysis, just that it doesn't add to the lengthening of the bones. Okay, so this is apophysis, and this would be the metaphysis, as you normally know in your long bones. Soft tissue edema, that's your that shows you again on a coronal. Now, things to be aware of is in a kid, in osteomyelitis in adults, your T1 is your friend, because focal areas of low T1 signal suggests of a marrow process, which can be infection or malignancy, and it should be lower. So iso or hypo intends to muscle, which suggests it's a marrow abnormality on T1. But in kids, we've got red marrow, which makes things a bit difficult, so T2 is your friend. And of course, in kids more than adults, infection is one of the top differentials, osteomyelitis, which is why we often give contrast. Now, some people say can do T1 pre-contrast and then post-contrast, but I find that sometimes with the fat, it makes it hard to see. So my preference is a T1 fat set pre-contrast and then T1 fat set post-contrast. But I think that's down to personal preference. So there shouldn't be, looking at these pictures in my head, there shouldn't be a differential of Ewing sarcoma, because the post-contrast things are the giveaway that looks like an abscess with surrounding enhancement. And a reason why is because this is a cortical breakthrough from the periosteo abscess. Now, osteomyelitis can happen. So we'll just go to the next slide first. So there are different bugs depending on their age. So 6 months to 4 years, you think of Congenital. If you've got sickle cell, you think of Salmonella. Staph aureus is the most common. And of course, if you have any penetrating injury, you're thinking of Pseudomonas. Often you get it in the metaphyses, like what Dr. Kapoor mentioned earlier. Of course, often the long bone metaphyses. Now, bone loss or osteopenia is only seen if you lose 30 to 50% of bone. And so if you have a normal x-ray, as per adult osteomyelitis, it doesn't mean that you don't have it. And so you want to use MR to further characterize what it is. And, like what we said here, periosteal reaction, periosteal abscess, really, soft tissue edema. You can have a joint effusion if it goes into the joint, okay, or even just a reactive appearance, a reactive phenomena. The only thing here is that bear in mind why it happens in the metaphyses is because you've got the vascular supply. It's very vascular there. And also you can get it in the subperiosteum or subperiosteal region, again, because the periosteum is very vascular. The only caveat is that if you are in a young infant, so if you're in a baby, and also in old adults, where you don't have that barrier, that physis barrier, because in infants, you've got transphyseal vessels, okay, so it goes across the physis. So in kids, in infants rather, because those vessels stop after infancy, after a year. So if you have them at a younger age, so infancy, i.e. osteomyelitis, you want to rule out septic arthritis because it can extend from metaphyses through the transphyseal vessels to the epiphysis and then subsequently into the joint space, i.e. septic arthritis. Same process goes into in adults. You don't have that physeal barrier, which is a vascular barrier. It just goes straight through, so osteomyelitis plus minus septic arthritis in adults and in infants. But above the age of 1, you get the nice avascular barrier of the physis, which acts as a protective layer. So your metaphyseal infection, which is often a hematogenous spread, does not go into your epiphysis and subsequently into your joint. However, it can spread transcortically into your subperiosteal space, hence giving you the signs of subperiosteal abscess. Some people say, do you start in the periosteum first or do you start in the metaphyses first? Nobody really knows. It's a chicken and egg situation. So some people only have just purely metaphyseal disease. Some have purely subperiosteal disease, and some have a combination of both. Okay, so that's osteomyelitis. So another example, so this is in a younger child. We can use ultrasound to help us delineate it as well prior to MR, but I personally prefer MR. So, but if you can correlate with both, even better. So on ultrasound, that's your ossification center of your distal femur. That's your femur, that's your bone, because bone's nice and bright. You've got soft tissue changes on top. You can see it's quite florid and should be nice and smooth, not looking very edematous. And then looking at the soft tissues, the bones here look quite craggy. Okay, so that's the axial or TS view. You've got a little fluid collection here, could represent a soft tissue collection, and there's some erosions going on here. So erosions, you need 2 planes. Unfortunately, I don't have 2 planes here. I've got 1 plane in the TS, and you should have another one in LS to confirm that it's a erosion. But then we look at it on the X-ray that was done. And in PEDS, we often like to have different modalities to correlate what we are seeing. We get better that way. And you can see that that's very ill-defined distal femoral metaphyses showing these bony erosions of infection. Okay. We've got another one. So septic arthritis of the SI joints, very common in kids. Don't ask me why. And what you're looking for is the characteristic sign. So this is T1. So you can see how that there's a lot of red marrow, so T1 is not really your friend in helping you tell whether there's marrow infiltration. But SEG stir is quite good. So that's your SI joint here. It's nice and it's there, nice and straight. And what you have here is just quite a lot of fluid, a high signal within the joint, extends outward into the soft tissues. And then post-contrast, you see these nice little abscesses within the soft tissues, and this is capsular hypertrophy or protrusion, and that's one of the key features to know if there's a SI joint effusion, this capsular bump at the top part of the SI joint. Okay. Next case. Candidate 3.
Yeah, this is a right shoulder X-ray for a skeletally immature patient. Okay, I'm looking at the bone to check if there is any bone abnormalities. I can see a widening at the space of the right acromioclavicular joint. And the right humerus look good, the epiphysis. The ribs, the trunk.
Do you want to ask me
Can
a
only
question?
see the right acromioclavicular joint is like there is widening.
Okay, so what if I tell you that you can feel a palpable lump or pain at the medial clavicle on the right?
At the medial clavicle at the right. Okay, I might see like an expansion seen at the medial aspect of the clavicle, and however, no cortical disruption or periosteal reaction. Does the patient have anything else like rheumatoid arthritis or known case of anything?
Nope. She tells you she's got right-sided pain, or she presented right-sided pain. Now she also has left-sided pain. So I've got more pictures.
Yes, please. Okay. All right. This is an MRI showing a bone marrow edema at both medial aspect of the clavicle with soft tissue edema surrounding it. And at the right ankle, there is also a bone marrow edema at the physis with lucency, lytic hypointense lesion seen at the physis with surrounding edema. So it might be due to multifocal osteomyelitis, since the patient have a multifocal site with bone marrow edema, soft tissue edema, and at the physis, which could be due to infectious process.
Yeah, well done. So going back to the first one, so you can see that there's actually expansion of the medial clavicle. You're right. There is no significant bony destruction, but what you have here is periosteal reaction along the medial edge, just underneath here, and possibly along the top. This is smooth periosteal reaction, suggesting this is a fairly chronic process. Because if you, like what Dr. Kapoor said earlier, when you have more aggressive periosteal reaction, the bone has not had time to lay down, so you get partial laying down bones, and then with destruction, so you get Codman's triangle. Can you imagine that the periosteum is trying to lay down, but part of it is just not, because it's being eaten away by whatever destructive process is. So there's smooth periosteal reaction, bone expansion. Now in kids, why is it that you see this? That's because if you think about it, go look back in your textbooks, your acromion ossification center is still cartilaginous, so you don't see that. But in any case, if sometimes you're thinking, oh, is there AC joint dislocation, I think that happens very infrequently in children, and what happens is that you actually get a avulsion fracture of the distal clavicle, and then subsequent to that you can get a very large periosteal hematoma, making it look a bit like malignancy. Okay, but then MRI will help you clarify it, but just remember your acromion ossification, actually I don't think it starts to form until you're about your 20s or early 20s or late teens. That's why you never see the acromion. Right. So there's MRs here now proving that on the right side you've got abnormal marrow edema. You can't appreciate the periosteal reaction as well, but maybe there's this elevation here and the bottom is bit well, and also on the left side, so bilateral clavicular involvement in your tibia, and fibula, and there's the fibula because you've got your peroneal tendons running along here. It's metaphyseal in region without the clavicles. You think is this infection, but putting 2 and 2 together, you rightly got it as a CRMO. You've got another case here, so same case of CRMO, but different patient, now showing you a more florid reaction in the bone marrow. But again, you can see that it's expansile, it's thickening, cortical thickening, and initially in isolation, we made a mistake of, I called it off, this is malignant because this looks aggressive. However, what happened was that we then did a CT scan, which showed that actually there's actually quite nice smooth periosteal reaction, suggesting that it's more of a chronic process, and because of the clavicular involvement, we are thinking more CRMO. Nowadays, with whole body MR, people use it to see if there are any other sites of asymptomatic disease, and often you're thinking things in the knees and ankles. It's one of those sites, and then you're looking for metaphysis involvement, but often they can cross the physes and be epiphysis as well, as in this case. So this was discussed in bone tumor unit. That's what we normally, because initial a thought, and given the MR findings, this was more likely to be CRMO. So just a little bit of what it is. So it has a relapsing remitting course. Of course, it's not non-pyogenic. Well, they say non-pyogenic because it's not. There's no bacterial growth. Typically multifocal, but patients can still have systemic features of like fever. So it's like a systemic GIA picture. It is more common if you are at higher risk if you do have some underlying inflammatory disease. So good for your question of is there any underlying GIA? You get multiple sites involved, and I said earlier, long bone metaphyses or metaphysis equivalents, and it's the most common disease to involve your medial clavicle. In the adults, you think of cepho, which comes with pustulosis and skin changes as well. And of course, like anything, when it's acute, it can be lytic, and then later as it starts to heal, you get that adjacent sclerosis, and of course, if it comes back again, you can have new lytic areas. So it's a waxing, waning course of disease, and use a whole body MR to screen. And if you've got multifocal disease, then it's more likely to be CRMO. But of course, you need to think about things like metastases, because if you've got a primary cancer, then of course, it can be, you correlate with clinical history, any weight loss, any systemic symptoms, how the blood markers. Sometimes you even do it's an abdominal ultrasound just to screen your normal things like Wilms tumor, neuroblastoma, and so on. A blood film to just make sure there's no evidence of leukemia. Okay. Right. Another case.
Okay, this is an MRI T1 and T2 fat sac for the left hip, showing surrounding joint effusion at the left side. This effusion surrounding the left femur. However, there is no definite bone marrow edema. At the acetabulum, there is mild breaching of the cortex seen. However, no bony lesion is seen. I'll think of septic arthritis, since there is a large joint effusion with no significant underlying cause of a bone lesion or anything to cause it.
Okay. So you've got more information. You go back to previous history and you see other findings within the patient's packet that the clinicians haven't told you about. What do you think?
There's a wrist X-ray for skeletally immature patient showing like the generalized osteopenia at the X-ray with multiple subchondral cysts. However, no definite bone fracture or bone lesion could be seen. There is some kind of ankylosis, I'm not sure about it, at the carpal bones. At the MRI, there is a joint effusion with multiple bone marrow edema at the carpal bones, and at the styloid process of the ulna. There is erosion also, and like soft tissue with multiple subchondral cysts. And on ultrasound, there is fluid with echogenic material, not clear fluid, with like debris. So I'm thinking of a systemic disease, maybe rheumatoid arthritis, since it's affecting the carpal bones.
Okay, and in good. And if you're thinking of an inflammatory arthritis in kids, is it called rheumatoid?
Juvenile rheumatoid arthritis, it's occurring more with ankylosis. It's the juvenile rheumatoid arthritis.
Yep. Okay, good. So well done. So MRI of the hip, T1 and T2 stir, and nicely picked up. There's a large joint effusion on the left, not on the right, as in there's always going to be a little bit of joint fluid that's within normal limits. What's interesting is that these presence of this synovial proliferation, almost looking like, very quite rice bodies like. It's just the appearance of it. Of course, we often think of it in something chronic, so like chronic TB, TB, RA. The interesting thing here is there's not much in the way of meridema, and if this was, of course, correlative clinical history, although sometimes it can be hard because, as I said, systemic JIA can have fever and raise ESR, CRP and stuff. But septic arthritis is going to be really painful, often acute flare of JIA or juvenile idiopathic juvenile inflammatory arthritis. People can still go on, they can still carry on, they are not in excruciating pain. So it can be grumbling for quite a while, and then it's incidentally picked up. So it's this synovial proliferation that's quite marked, and the absence of meridema. Often in septic arthritis, there will be some extent of meridema, and of course, prolonging it without treatment, you start to get more in the way of bony destruction, because of the inflammatory process. Now, in small thing, so we MRI of the hip, we also look for other features. In this T2, there's probably irregularity of the chondral surface. It's probably just an incidental osteochondral lesion that's not associated with the underlying process. On the other X-rays, so what you can see here nicely picked up is that you've got, I guess it takes time to get your iron, but if you look at quite a few wrist X-rays of the same age, you notice that there will be a bit more joint space between the proximal carpal row. Distal carpal row still looks okay. This the mid carpal row. The space is quite narrowed. It's called a bit of carpal crowding. There's also sclerosis. It just doesn't look very happy in the proximal carpal row. On the left and on the right, you can see it's actually, there is a widening of the scapholunate. You've got decrease, you've got the subluxation of the capitate, all looking a lot like what you think in rheumatoid arthritis if it was in an adult. Similarly, the changes on MR shows the bilateral joint effusion. All these little cystic-like appearances could be subchondral cysts. Could be represent erosions more than subchondral cysts. Probably not really erosion given the extent of disease. Now, on ultrasound, this is your classic view of your wrist joint, the radial carpal joint in the midline of your wrist, and the black bit shows synovial thickening. The only bit that I didn't give you was the Doppler, which would show a vascularity, suggesting it's active synovitis. So in rheumatoid, or rather in arthritis in a child, you can get, if you just had treatment, you can have a lack of the Doppler vascularity, but you still have synovial thickening persisting for a bit until the treatment starts to kick in. But you can just notice that on the right side, it is a lot worse than the left, which corresponds with what the patient's symptoms are. Okay. So JIA, juvenile idiopathic arthritis. Apologies, I always use JIA, so I don't really think about what the full name is. So there are different subtypes. They are, of course, beginning before 16 years old. We are not going to the different subtypes here, but you just got to realize that they can be monoarticular, polyarticular, it can be oligolar articular, enthesitis related, so something looking like ankylosing spondylitis, so different types. But technically, all you're looking for is inflammation, joint inflammation. Carpus, your carpal bones, the most site of fusion, the earliest sign is carpal crowding. You don't really get the fingers, you don't really get erosions in the fingers, I'm not sure why, but often affects large joints, your wrists, your knees, your hips, your ankles. Okay. And of course, with hyperemia, you can get very long gracile bones because of the hyperemia, balloon or enlargement of the epiphysis and your intercondylar notches. And if you think of enlarged intercondylar notches, the thing you think of is hemophilic arthropathy. Again, same process. You keep bleeding to the joint. You get constant inflammation causing hyperemia causing your bone changes. Same thing. Okay, but easy to think is that whether it's their family history of hemophilia, a simple test to just make sure that the screen. So just some things to show you the difference. So patient, both legs, one has more affected with arthritis on the left and not on the right. You can see the epiphysis is a lot bigger on the distal femur and the epiphysis as well. And then this is one that has a bilateral JIA involvement of both knees. And you can see that widening of the intercondylar notch. To be fair, I think it's hard to, if you are just looking at symmetry, if you're looking at symmetrical both sides without one to compare, then in the absence of other symptoms and purely isolated widened intercondylar notch, I think it's hard to pick up. Okay, and I often have to go back to see compare it with age-matched controls to say, is it truly widened or is it just a projection thing? Patient has these long gracile bones flaring of the metaphyses and epiphysis with osteopenia, erosions, and all of this, and the joint space narrowing. So remember, in inflammatory pathologies, even in kids, your joint space narrowing is diffuse because it is coated by synovium that's inflamed, versus in an older patient where osteoarthritis is quite focal because it's in the weight-bearing aspects. Okay, so inflammatory diseases affecting the joints often give you diffuse joint space narrowing and not focal. Okay. Right. Now, the other thing that's quite common in kids, we see Baker cysts, or rather fluid within the semimembranosus medial gastrocnemius tendons, the bursa. It's a space, and we often see a Baker cyst. A Baker cyst is idiopathic, but you can also think, is there something driving fluid production, causing it to leak out into the bursa, because it often communicates with joint. You do see it in ages from 2 to 14. And the different thing here is that we always need to make sure on the MR, if you see a Baker cyst or even an ultrasound, make sure there's no underlying cause like an inflammatory arthritis or something else that's driving it. And 2 different patients, and you can see that on this one, you've got synovial thickening, and synovium is based on MR on T2, is these low signal fawn-like bits that coats the joint capsule, the space, the joint space, and that's that's basically a inflammatory process driving this Baker cyst production versus one that has mostly joint fluid within the Baker cyst, but none really in the joint space, and no evidence of synovitis. So I think this is just to let you know that if you do have a Baker cyst, although it's reported, just make sure that there's nothing else underlying that's driving it. Okay, next type of case. How are we? So, okay, yeah, continue, candidate 3.
Yeah, this is a pelvis X-ray for a skeletally immature patient. This pelvic X-ray. Okay. What's the history? What the patient complaining of?
Altered gait.
Okay.
This was a family history. Patient was first born in a breech presentation.
Yes. Okay. I will check if there is any signs of DDH for hip dislocation. As I can see at the right side, there is mild disruption of the Shenton line, and the femoral head epiphysis is slightly smaller, asymmetrical. I want to see the Herglian line, if the femoral head is within 2/3 medially, and if there is soft tissue swelling or elevation. It's a bit tilted, the pelvic X-ray, not well centralized. However, I will raise the suspicion of right-sided DDH.
Yeah, well done. Yep, correct. So all the key salient features I mentioned. So Shenton's line, we'll go through that, but this is the left. So the left is the normal one, the right is the abnormal one. It's nice line drawing from the obturator foramen all the way down. Makes a nice smooth curve. You can argue that this is not quite smooth. You can see one line here and then another line here. So there's disruption of Shenton's line. There is asymmetry of the femoral epiphysis. One side smaller, one side bigger. The other thing that to look for is that if you draw lines, which I'll show you on the next slide, you draw a line through this. I believe this is the Perkins line. I always get those confused, but essentially a line through the triaradiate cartilage, another 90 degrees down along the lateral aspect of acetabulum. So if you draw one here, okay, and draw one here, this should be in the lower inner quadrant, and this is kind of a bit more laterally positioned. So there is a subluxation of the hip. Other small things you can think of is an acetabular angle. Okay, you can draw one here. So using this, I think it's Perkins line. And then you do the angle between here and here, and then the angle between here and here. Okay, so this is a steeper angle, and this is a bit more, yeah, so this is a steeper angle than this. Just remember, as you age, this bit line should come down. Okay, so just making it flatter. but this is it's a slightly larger angle. Okay. So next slide shows you all the key features, and now you've got a left-sided DDH because this femoral head should be in here. Okay, so my history wasn't the best because essentially if she had breech presentation, if she had family history, if she was firstborn, these are key risk factors of highly suspicious of DDH, and all of them under the NIPI guidelines, neonatal hip screening guidelines. Can't remember the full term. In the UK, they would be subjected to an ultrasound within the first 4 to 6 weeks. Okay, so these, so essentially, if we had missed her, that's because either she missed an appointment or there was something else. So technically, a lot of babies are now early DJs picked up early. They can put in a Pavlik harness and monitored with time so that it can be corrected without surgical intervention. Okay, so that's that. Now, DDH, just a little bit of DDH, the reason why we do it as early as possible, so 4 to 6 weeks, and then we can monitor them up to about 4 to 6 months. That's because of the ossification center. So when you do I have no pictures to show you of the ultrasound, but you know, we have a lot of techniques out there. The most commonly known as the graph technique for ultrasound. You can look it up on YouTube or on a book. And they do it, they say less than 4 months. That's because when you start to have ossification of your femoral head, it makes it hard because the calcification or the ossification blocks your sound waves passing through, so you can't actually see the positioning so well. So 4 months because that's when your ossification center has not yet formed, and it forms after that. Some people push it to 6 months because everybody ossifies at a different age, but I'll say no later than 6 months. Okay, so by 9 years old, by 9 months and onwards, you are really using X-rays to help you to ensure or to characterize if your hip joints are in place or not. Okay. All right, next case.
This is a pelvic X-ray for a skeletally immature patient, showing at the left hip there is a widening of the joint space and decreasing of the left femoral head epiphysis, decreased in size and increased in density, shows sclerosis. The growth plate appear good, so findings are most likely suggestive of Perthes disease, AVN of the left femoral head epiphysis, due to decreased and collapsed of the left femoral head epiphysis and widening of the joint space, which is joint effusion is the early sign.
Okay, good. So you've got another MR. So we did MR on this child. Do you want to talk me through this? Does it confirm or refute what you initially thought it was on X-ray? Candidate 3? Do we just lose you? Hello? Co-host, have I done something wrong? Candidate 3 has disappeared. Candidate 3? Okay, if you're not back in the next 5 seconds, we'll probably move on to candidate 4. Hang on, let's see what's going on. It's an internet problem. Okay. So sorry to put candidate 4 in a spot. Candidate 4, do you want to take over? You can start. Whether you agree or disagree, you can start from the previous slide.
The X-ray is showing that the left femoral head is sclerotic and deformed. The rest of the bones appear normal, so this could be avascular necrosis of the left femoral head.
Okay. And then how about the MR?
On the MR, I see that there is the left femoral head. There is a T2 hyperintense area with surrounding edema. There is also a hypointense line on T1. So this is, yeah, this.
Are you changing your diagnosis? Are you adding more to your diagnosis, or are you keeping with the same diagnosis?
No, I want to change the diagnosis
Okay.
because this doesn't look to be avascular necrosis. This looks to be a T2 hyperintense area in the in the neck of the femur with surrounding edema. So T1 hypo, T2 hypo.
Okay.
I'm not sure what's this.
Do you want to hesitate? Just say something, anything that comes to your head, as in any differentials at all. No judging here.
T2 hyperintense with edema in the epiphysis would be like a plus tumor.
Okay, cool. All right, so same MRI. We're going back to the X-ray first. So as what everyone has mentioned, there is flattening, there's sclerosis of the femoral epiphysis. There is some lucency here. Okay, it's not there. Okay, on the other side, and essentially the hip is still enjoined. There's no slip at all. And when you look on the MRI, so that's T1, T2, and post-contrast, there is that lucency corresponds to this low T1 or isointense T1, high T2 lesion within the metaphyses with a little of a contrast enhancement. Some joint fluid, but not much in the way of synovial thickening, okay, because all of these probably just be of joint capsule. So this is a trick question, and I think it also tricked us all. The only thing here was that we did raise a possibility of infection just because it was at the metaphyses. You've got all these marrow signal change as well. However, this is on the background of Perthes disease or avascular necrosis of the femoral head epiphysis. The only caveat to this was that the patient was very, very well. Okay, there's no systemic features of infection at all. And so what we have is that that's actually cystic metaphyseal changes. So as I said earlier, so this is Perthes disease where you have flattening of the femoral epiphysis, and on imaging you get sclerosis, fragmentation, flattening, and then you have these cystic metaphyseal changes, and with time you get enlargement of the femoral head, you get flattening, you get a very short neck or coxa brevis, and then you've got this and you can get femoral head extrusion, FAI, labral tears, everything consequent to that. Your peak age is always about 4 to 8, so often it is above that of transient synovitis as a cause for a limp or hip pain. So it's older than transient synovitis because that's kind of below 3, and it's younger than your SUFIs, which is really in your adolescent age. Okay, so your Perthes or AVN of the femoral head is kind of the one that's in between. Now, coming to the metaphyses, metaphyseal cysts, so we see earlier, so they are really, so these ones here, people don't really know what it's due to. There are some theories that they could be due to because you've got growth plate disturbances, because you've got the femoral head necrosis, so these tongues of physeal cartilage that have like protruded into it, and because of the changes in blood supply, these are areas of unossified cartilage which have persisted, so causing these cystic-like appearances. Or is it fragmentation of the trabecular bone? Is it some deposition of fibers of fibrofatty tissue or granulation tissue because of whatever that altered blood flow that's within that hip joint? The cool thing is these are actually not very rare, and in literature it's reported that they are seen in a delayed phase of Perthes disease. So it could actually help you to actually say this is Perthes disease, okay, to be quite confident. But of course, I'll say take a pinch of salt, always correlated with the clinical history. What does it tell you? Yeah, so Perthes, you can also get spontaneous revascularization, so the disease can hold on its own. As I said, nobody really knows why Perthes happen. In an older person, so in an adult, if you've got avascular necrosis of the femoral head, you think steroids, you think alcohol, pregnancy, stuff like that. But in kids, it's really idiopathic, nobody knows. Disruption of blood supply, probably, or alteration to the blood supply. And so here we see in the first stage, you get this collapse and sclerosis, like what we saw in the metaphyseal lucency. These pictures are from radiology assistant, which demonstrates it nicely. And then you've got progression to fragmentation and development of a very short, broad column, the coxa brevis, if I'm not wrong. And then finally, you get this coxa magna deformity. Okay, so that's, and of course, when you see that, you always have to think, is this secondary avascular necrosis? If the patient has radiotherapy or chemotherapy because of leukemia, lymphoma, is this something like a multiple epiphyseal dysplasia, but you can see the progression? And the other thing is Myers dysplasia. Okay, now, Perthes, we'll take it out, is really avascular necrosis, or you can think of it as a osteochondritis desiccant or osteonecrosis. So the next few slides, I'm just going to show you different how it can, so Perthes-like diseases, but in other areas of the bones of the body. And so if you take away Perthes and think of it as an osteonecrosis syndrome or osteonecrosis pathology, then that makes then that helps with the next few slides. So if you don't get in the hip and you get it in the elbow at the capitellum, because that's your radius, at the elbow, you can call it an osteochondral lesion, osteochondral defect, and this one is a defect because you can see that there's actually breakage or fracture of the osteochondral junction, and there's also a free fragment here. So people say you can differentiate between Pennier's disease. If Pennier's disease is just osteochondritis desiccans or osteonecrosis, but without floating fragments, and something a bit more, you can call it an osteochondral defect. It's what this one is. Okay, so osteochondral lesions are just alterations within the osteochondral junction, but you don't have this floating fragment. So I leave the floating fragments for osteochondral defects. And I think it's easier to kind of describe it rather than to put the eponymous names on it. Okay, so I think we've mentioned a lot of this. So people don't know, was it due to genetics, repetitive stress, ischemia, some combination? So osteochondritis desiccans, some called chronic osteochondral injury, and then fracture or defect, as I call it. And I think the important thing to take away here is that you are looking for features of an unstable lesion. It can happen in the knee, it can happen in the elbow, and you're looking for that fluid signal or cystic changes around the fragment, of course, a free-floating fragment within the intra-articular body, and your discontinuous overlying articular cartilage. Okay. Other areas of osteochondritis, which you might know, so metatarsal heads, Freiberg's, the navicular, there is a name for it, I can't remember, Kohler's, at the base of your metatarsal, fifth metatarsal, called isolins, but just remember it can be a chronic traction injury, so similar, or fracture or apophysis. So this one's a hard one. And things to look out for is whether you've got soft tissue swelling, whether patient's asymptomatic, because this could also be a normal apophysis site. Don't confuse that. So apophysis are always vertical, fractures are transverse, lucencies are transverse, and you've got stress fracture, Jones fracture, avulsion fractures, but essentially if there's a fracture there, you call it transverse lucency. And of course, you get Sever's disease, which is fragmentation and sclerosis of the calcaneal apophysis. Things to note is that you've got a lot of normal variants that can look like that, similar to the apophysis here. So if you see sclerosis, don't always call it Sever's disease. Just make sure that patients, just correlate with patient symptoms. Okay, because normal apophysis can also look like this. Okay, candidate 4, you continue. So next case.
I'm candidate 3. I'm back.
Okay. Yeah, if you do this case, this will probably be your last case. Okay, well, I can give you another case. It's no problem. Yeah, please continue.
Okay, this is a pelvic X-ray for a skeletally immature patient, and showing widening in the growth plate at the left hip, and the left femoral head epiphysis. It's showing it's posterior medial, where there is a disruption. If I draw the Kellen line, it's not crossing the femoral head, and it's more prominent on the front view. So findings are suggestive of SCAFI, stepped capital femoral epiphysis at the left femoral head, where there is widening in the growth plate, and the left femoral head epiphysis, it's moving posterior medially, and it's not intersecting the Kellen line.
Okay, so you've got another you've got MRI that was done. Does it confirm or refute your diagnosis?
Yes, it confirms there's The femoral head epiphysis, it's subluxed posterior-medially with joint effusion, and findings are suggestive of split capital femoral epiphysis.
Yeah, good. So exactly what you said. So there's asymmetry of the physeal line. So you've got widening, your sclerosis, and most importantly, you've got the slip, which is best identified on the front lateral view. You talked about Klein's line. We'll talk about that in a bit. So that's slipped. And then if you look at the next slide, which is the MRI, you can see the slip quite nicely with adjacent meroedema. T1's best to see the physeal widening, you can see here, compared to this nice and thin black line, and with reactive edema. Important thing to note is that there's no slip on the other side, because you can get one slip can herald another slip. And I can't remember what percentage of it is bilateral. It might be in the next slide. Yep, so 18 to 80%. Often we call it a Salter 1 Harris fracture, because it's through the physeal growth plate or the physis. And there are chronic stress or weight bearing. Often it's people or in children who are a bit bigger, higher BMI. And I find the asymmetry of the physis one of my more sensitive markers, because early slips you may not be able to actually see the slip, but front leg lateral would be the more sensitive view to then the AP view to look for the slip. And if still in doubt, then do an MRI, because what you're looking for is that physeal elongation on T1, as I mentioned earlier, that meroedema, and of course synovitis. And MR can help you also to identify other lesions which may not have picked up to cause pain. So you mentioned the Klein's line. Now I don't think the Klein's line is used in a front lateral view. Off the top of my head, I thought it was only in the AP, and certainly I've only used it in the AP. So you're abnormal. So you're basically drawing along the lateral aspect of your femoral neck, just along a parallel line, and you should see your femoral head protruding beyond the line. If there's a discrepancy of more than 2 millimeters between both sides, then you call it abnormal on the side that you don't see the femoral head protrusion over the line. Okay, so that's your Klein's line. Okay, candidate 3, maybe last case for you, and then we'll move on to the other guy, to the other candidate. Sorry.
Okay, this is pelvic X-ray. At the pelvic X-ray, I can see at the right iliac bone there is like periosteal reaction. There's a small fragment. It might be there's an avulsion fracture. And the MRI it shows there's bone marrow edema and soft tissue edema with cortical disruption at the right anterior superior iliac spine. So I think findings are suggestive of avulsion fracture of the right anterior superior iliac spine, where it's the insertion of the sartorius, I think. Yes, muscle.
Yeah.
So it's a avulsion fracture.
Sorry?
It's a avulsion fracture.
Yeah, that's right. That's right. So a avulsion fracture, you can see, is an older child. The growth plates are almost fused. And main things to note is that in kids, you need to know all your sites of potential avulsion fracture. And what you look for is the asymmetry between one side and the other side, making sure it's a properly centered radiograph. And this one it was, but I think the orthopedic surgeons just wanted further clarification on how it looks like, and hence we've got a nice image for teaching. And I think on first impression, had you not seen the if you just saw this in isolation without the X-ray, you can think, is this something a bit more worrying because of the meroedema, because of the soft tissue swelling? Can it be something a bit more sinister like sarcoma? But then seeing the X-ray is very reassuring, and of course seeing the axial showing that cortical disruption, so that's your cortex and it's kind of fallen off, and with hematoma and callus formation and healing. So it can be due to a single repetitive trauma, your disruption of the tendon or bone. Often it's 15 to 25 years of age, sports person. But if you think in an adult, if you get an avulsion fracture, often in the lesser trochanter, you're thinking of something like a pathologic or insufficiency fracture. So I think that's the key thing here. Avulsion fractures usually thin crescentic bone fragment, distracted, maybe or just a very faint one, and you get very exuberant callus formation. So it's important to just to look at the plain films, because it will give you quite a lot of answers, or going back to initial, or finding out the history of what happened. Was there a pop sounding, or was there some sports involved? So history is quite important here. So common avulsion fracture sites on this. I think everybody should know this anyways, so I wouldn't hang on too long.